This is the third video in our OMI series and the first of two on developing dynamic eyes for occlusive MI. We'll introduce two new principles in this video, reperfusion and reocclusion. These principles answer two questions respectively. First, what happens on the ECG when an acute coronary occlusion is reperfused? Second, what happens on the ECG when a reperfused occlusion is acutely reoccluded? What happens on the ECG when a coronary occlusion is reperfused depends on how long the occlusion has been going on for and whether necrosis is present. If the occlusion was brief, then you might see hyperacute T waves that had started to form return to baseline. We call this normalization. If there was necrosis, though, which usually will be the case, you may see T wave inversions form. First towards the terminal part of the T wave, then more symmetrically as time goes on. This leads to our reperfusion principle. If necrosis, then T wave inversions form. First terminally towards the end of the T wave, then symmetrically. If no necrosis, which is less likely, the relative T wave area will improve. This is called normalization. Many of us recognize the tracings associated with the reperfusion principle secondary to Wellen syndrome, which specifically refers to these ECG findings in leads V2 and V3 in the setting of a patient with improving or resolved chest pain. It's important to note a third reperfusion marker, an accelerated idioventricular rhythm. This wide complex rhythm between about 50 to 110 beats per minute occurs in 8 to 20% of patients, usually during the first 2 days after MI, and is often provoked by reperfusion. So now we have our reperfusion principle and our three reperfusion markers: normalization if no necrosis, T-wave inversion if necrosis, terminal, then symmetrical, and AIVR. What happens on the ECG with acute reocclusion of a recently reperfused artery? Let's turn to this example from Jesse McLaurin's ECG Cases blog to illustrate. At time 0, we have a patient with recently resolved chest pain who has some inferior T-wave inversions consistent with potential reperfusion. 10 minutes later, they develop chest pain, and the ECG that's obtained isn't really too remarkable for markers of acute occlusion. 10 minutes later, they still have chest pain, and now we can see some J-point elevation developing and some concerning area under the T wave in proportion to the QRS. In the next 10 minutes, the pain still persists, and then we can see an obvious STEMI criteria meeting set of tracings. This all illustrates the reocclusion principle, that reperfusion T-wave changes can appear in reverse. An important concept to take away from this example is pseudonormalization. In the setting of acute reperfusion, initial ECG changes may be virtually indistinguishable from a patient's baseline ECG. Pseudonormalization underscores several important realities of diagnosing acute coronary syndrome. First, acute coronary syndrome is a clinical diagnosis. Second, a single ECG can rule in coronary occlusion, but it cannot rule it out. And third, serial ECGs, when correlated with the patient's symptoms, can let us diagnose dynamic coronary occlusion when a single ECG could not. Let's review what we introduced today. First, the reperfusion principle. Second, the three reperfusion markers: normalization if no necrosis, inversion if necrosis, terminal then symmetrical, and acute idioventricular rhythm. And finally, the reocclusion principle. Reperfusion T-wave changes can appear in reverse. beware of pseudonormalization, and good luck with developing dynamic eyes for reperfusion and reocclusion.